Welcome to AETCM, the Emergency Medicine channel. Today we are going to discuss a case of altered sensory. Thank you, sir.
Okay.
A 67-year-old male, known case of CLD with portal hypertension, presents to the ER with altered behavior. On our initial 10-second assessment, the patient was conscious but not oriented.
Okay.
Coming to our primary survey,
So we have a CLD patient with low sensory. So what all can it be?
It can be a case of hepatic NCUP.
Okay. Most common cause of altered sensory in here?
CV, hyponatremia.
Most common cause is hypoglycemia. So it can be hypoglycemia because of the CLD or hepatic disease. So hypoglycemia is there. Then second, you told hepatic encephalopathy. Then
hyponatremia.
Okay, hyponatremia can be there. Then
CV is.
Okay, CV can be. Pertaining to CLD, what else? Hepatic encephalopathy, that is fine. Other than that, a patient might be having coagulopathies. Coagulopathies will be there. So that coagulopathy itself can cause intracranial bleed and all. Okay. Then again, as you told, alcohol. If the patient is took alcohol again, it can be because of alcohol withdrawal or alcohol intoxication. Okay.
The airway was patent, no cooling of secretions, no hoarseness, no stridor. Breathing respiratory rate of 16 per minute, SpO2 of 95% in room air. Circulation BP of 100 bar, 70 millimeters of mercury. Heart rate of 80 beats per minute. All peripheral pulses equally palpable. Disability coming to GCS, E3, V4, M5. People bilaterally equally reacting to light. Exposure wise temperature 98.2 degree Fahrenheit and GRBS of 160 milligram per deciliter.
Okay, in the primary survey, we found that the GCS is low. It is only 12, right? 12 by 15 and GRBS is normal. Okay.
Coming to adjuncts of primary survey, ABG showing a pH of 7.
The first adjunct, what is it? First adjunct, what you should use? GRBS. Okay.
Since our VBG is showing glucose, we initially took the
Okay.
pH of 7.350, PCO2 of 40, bicarb of 22, lactate of 2, sodium 122, HB 12.4 and potassium of 3.8. ECG showing normal sinus rhythm. CBC CRP was taken showing CBC of 5000, CRP of 7.5.
So what all conclusions did you make after this much investigations? You ruled out hypoglycemia. Then
electrolyte imbalances, sodium, everything was normal.
Sodium in our VBG sodium value will be slightly normal. So we will have to send for the lab sodium. Either it can be hyponatremia induced or other. So we will have to evaluate for that. Okay, sodium we have found. Then ECG. Why did you do ECG? Where is suspected ethnics? Okay, ECG. Okay. So through CBC CRP you ruled out infection. Okay. So this patient, what is your from the primary survey? What can it be? What is your impression?
There was no acute acid-based disorders as such. The counts, everything were also within normal limits.
So what might be the cause of altered sensory?
It can be any other precipitating factors that might lead to an hepatic encephalopathy.
Hepatic encephalopathy. So what are the precipitating factors of hepatic encephalopathy?
It can be melena, hematomesis.
It means upper GA. Okay.
Infection we already ruled out. Loss of increase in the uptake of protein. Constipation.
Increased dietary intake of proteins or animal proteins. Okay.
Then constipation can be diuretic intake, dehydrations. ABG wise, we also ruled out alkalosis. We have ruled out hypokalemia, which we ruled out.
From history, what all we should ask other than this many things? From history, we should ask whether he took alcohol these days. The alcohol can again precipitate encephalopathy. Then in the ABG, what else should we check? Should check potassium. Why potassium?
Because hypokalemia can precipitate alkalosis and hypertension itself can lead to...
alkalosis can cause hypokalemia. Okay, hypokalemia can cause alkalosis. So What will potassium do? What will happen if potassium is low?
It can cause alkalosis in the that can lead to increased alkalosis can lead to decreased formation of NH4 plus. That means ammonia get accumulated and further precipitate hepatic.
Two more things are there. Because of hypokalemia, there will be hypokalemia induce some ammonia generation will be happening in the proximal convoluted tubule. So that can cause increase ammonia genesis and that can cause hepatic encephalopathy. Other thing is hypokalemia can cause periodic paralysis like decreased bowel habits, constipation, everything. That will again lead to problem in excretion of ammonia. Okay.
Coming to sample history, a 67-year-old male non-case of CLD with portal hypertension presented to the ER with complaints of altered behavior of 3 days duration. It was gradual and progressive. It was associated with abdominal distension and constipation. There was also history of altered sleep pattern, no history of any fever, headache, abdominal pain, dysuria, vomiting, loose stools, breathlessness, melena, hematemesis, or increased protein intake. There was no history of any loss of appetite, slurring of speech, angle of mouth deviation, seizures, or obstipation. No allergic history. Coming to drug history, the patient was taking lactulose syrup. There was also history of similar episodes in the past.
So we got history of constipation here and altered sleep pattern. So altered sleep pattern means what encephalopathy can do?
Basically, altered sleep pattern is seen. We can grade the hepatic NCUF into 4, grade 1, grade 2, grade 3, grade 4. In grade 1, there can be altered sleep pattern. In grade 2, hepatic NCUF, there is flapping tremors can be present. Grade 3, the patient can be in semi-stuporous state. Grade 4, the patient is in coma.
So already through history, we understood that he is in grade 1 hepatic encephalopathy. And the rest of the things through examination only we will be seeing. Okay.
Coming to general examination, ictus was present and also periodema was present.
Okay.
Systemic examination, GIT, soft non-redundant bowel sounds plus CNS examination, patient was conscious but not oriented. GCS of E3, V4 and M5. Flapping tremors was present and there was also hyporeflexia. Other systems was within normal limits.
So other system in the GIT, what should we check? We have a probable hepatic encephalopathy patient.
We can check for ascites, any shifting dullness of fluid thrill as such.
If ascites is there, what should we suspect?
We can suspect SBP as well.
SBP might be the precipitating cause of hepatic encephalopathy. Okay.
Then we come to a diagnosis, that is CLD with portal hypertension in type C overt hepatic NCUF, grade 2 episodic, which is precipitated by constipation.
Okay.
Coming to the differential diagnosis of altered mental status in cirrhosis, there can be intracranial hematomas, thyroid dysfunction, acidosis, drug intoxication, hypoglycemia.
Which drug intoxication will cause hepatic encephalopathy?
Diuretics.
Intoxication means usually it will be sedative. Benzodiazepine. Okay.
Hypoglycemia and both hyperglycemia. Infections like encephalitis, severe sepsis, uremia, hypoxia, and hypercapnia can also be other DDs of altered mental status in cirrhosis.
In this patient, we know that this patient is having constipation. So maybe it is because of that. So if we have another patient, there is no typical history that is attributing to hepatic encephalopathy. Then what extra investigations you will have to do? You ruled out hypoglycemia, hyponatremia is not there, hypokalemia ruled out. Then infection CBCRP is normal. There is no alcohol history, there is no GI bleed, no excess ammonia, excess protein intake. What else from this?
We can either go for imaging or we can go for ascitic tapping.
No ascites also.
Then we can go for imaging.
No, what else should you suspect? New onset renal failure you need to suspect because patient can go in for HRS and all that. In such patients anyway there will be ascites, but you should while doing the initial investigations, along with the other tests, you will have to do a renal function test also. That also might be the cause of.
Then come to precipitating factors associated with hepatic income, hyponatremia, jail bleed infections, dehydration, fluid restrictions, diuretics, excessive parasynthesis, vomiting, diarrhea, sedative drugs, alkalosis, azotemia, hypokalemia, and excessive protein intake and constipation are the most precipitating factors of hepatic income.
Okay.
Coming to the grades of hepatic encephalopathy, the Westhaven criteria is used. There is both covert and overt hepatic encephalopathy. Covert comes under the grade 1. Grade 2, grade 3, and grade 4 comes under overt hepatic encephalopathy. Grade 1, there is altered sleep pattern and decreased attention span. Grade 2, there is flapping tremors. There will be hyporeflexia. Grade 3 is characterized by a semi-stupor state and hyperactive deep renal reflexes. Grade 4 is common. Coming to the classification of hepatic encephalopathy, there are basically three types: A, B, and C. A, hepatic encephalopathy basically due to acute liver failure, that is within 7 days. B is due to portosystemic bypass, most commonly that is TIPS. C is related to cirrhosis and portal hypertension. That's why in our diagnosis there is type C hepatic encephalopathy.
Okay. What else? How did you treat this patient?
Basically, in our patient, the diagnosis first and precipitating factor was constipation. So the mainstay of treatment is bowel wash and lactulose.
How do you do bowel wash?
We will go for lactulose that's used in the rectal stab. We will be giving, which is a non-absorbable disaccharide that will causes acidification of the intestine. As a result, more H plus is created. That the ammonia will combine with the H plus and produce NH4 plus.
It will produce ammonia.
Thus, ammonia washout will be taking place.
Suppose this patient is hyperglycemic, and if you are giving lactulose, will that increase the sugar? No, it will not increase the sugar. Okay. Then lactulose, either you can give it as syrup or you will be giving it as per rectal. So what is the dose of syrup? What is your target? How much stool?
2 to 3 episodes.
Okay, 2 to 3 soft stools. Soft stools. Okay. Either if this patient is conscious, we can give oral, or otherwise we can give per rectal enema. How much should we give per rectal? Can give 300 to 700 ml almost can be given. Up to we can give like 4 times a day. 4 to 6 times actually a day. And oral, how much will you give? We can give 30 to 60 ml can be given hourly. Can be given till the patient passes stools. Okay. But we only want 2 to 3 stools, soft stools a day. Okay. Then what else?
We can give injection perino, which is a prokinetic agent. And basic content will be metoclopramide.
Okay. What is the contraindication for perino? Renal failure. Okay. Then
we can give other things like rifaximin can be used.
What is the dose of rifaximin?
400 mg TID can be given. That also has a role in excreting the ammonia, detoxifying the ammonia.
Okay. So first we are giving lactulose. Before that, we need to find the cause. First, the cause. Whether it is infection, hypokalemia, increased protein diet, or GA bleed, whatever the causes that need to be evaluated and treated. Then we will have to give lactulose. This patient anyway is having constipation. That can give you lactulose should be given. Then rifaximin. Rifaximin, how much you took? 400 TID. Then, or we can give 550 BD. 550 mg BD. Okay,
then other drugs we can give like L-methynyl aspartate can be given.
That is not. Other than ammonia, what else will create hepatic encephalopathy in a patient?
phenols, mercaptans,
short chain fatty
fatty
acids, these
acids.
things can. But ammonia is the only investigation which we can do in the lab. But is it correlating to the grade of hepatic encephalopathy?
No, it does not
It
correlate to
does
that.
not correlate.
In diagnosing that.
Okay, what else? If the patient is having associated infection, we'll have to give antibiotics. If this patient is having hypokalemia, we'll have to correct the potassium. Then, if the patient is having cerebral edema, these things we should give hypertonic saline or mannitol, depending on that if it is present or not. Then, what should be the diet?
The protein should be decreased.
Okay, low protein diet. Low protein diet. And whatever the causes, that cause should be managed. Then, how was the patient now?
Initially, we start the patient on bubble wash, and after passing 2 to 3 soft stools, the patient started becoming better. The sensorium started becoming normal.
Okay. Okay. Thank you.